Good afternoon, and welcome to the webinar on CMS's new Interoperability Initiative, which is co-sponsored by the Alliance for Home Health Quality and Innovation and the Visiting Nurse Associations of America, or VNAA. My name is Teresa Lee, and I'm the Executive Director of the Alliance for Home Health Quality and Innovation. By way of background, the Alliance was founded in 2008 and is dedicated to the mission of leading and fostering research and education on the value that home health care has to offer to patients and the entire U.S. healthcare system in support of quality and innovation. VNAA is a national association that supports, promotes, and advances mission-driven providers of home and community-based healthcare, hospice, and health promotion services to ensure quality of care for their communities. The Alliance and VNAA are very pleased today to provide an overview of the new CMS and HHS Office of the National Coordinator for HIT efforts to support health information exchange through Medicaid funding. We're very fortunate today to have as our guest speaker Tom Novak of the HHS Office of the National Coordinator for Health Information Technology. Tom is the Medicaid Interoperability Lead in the Office of Policy at the Office of the National Coordinator, where he supports the advancement of Medicaid interoperability in the drafting and review of federal regulations. He is detailed part-time to the Centers for Medicare and Medicaid Services, CMS, Medicaid Data and Systems Group, where he provides direct support to state Medicaid agencies and state governments on health information exchange, funding, and strategy. Before we get started, I just wanted to cover a few housekeeping notes. First, Tom will speak for approximately 40 minutes, and we'll leave the last 15 minutes to answer questions. Please note that this is a webinar, and we control the slides on our end, so please do not be surprised if you can't flip ahead. Second, your lines will be on mute. You can submit questions to be answered during our Q&A period through the webinar chat box on your computers or other devices. And you can submit those questions at any time during the webinar. We'll just hold the questions until the very end. Finally, we will be making the slides available to participants after this webinar. We are also recording the webinar and will make the playback available as well. Without further ado, I'm going to turn this over to Tom Novak. Tom?
Thank you very much. As said, I am Thomas Novak. I'm with the Office of National Coordinator for Health IT. I have two jobs. I'm with the Medicaid Data Systems Group. What that means is I sort of sit, I tell it works, doesn't really matter, but I cover health information exchange, both from a policy side and sort of from a architecture side, helping states think through the design of such health information exchanges, as well as I work on the policy on the federal side to support them. I want to spend some time today to talk to everybody about something that is relatively new. It came out February 29th, about the ways Medicaid can support health information exchange and activity, and I want to sort of set it up by talking a bit about the background of what we already could do and then what changed. And the what changed part is what I think is very interesting to everybody here today, because we could do a lot more support for interoperable functionality for supporting home health or social service providers or other sorts of provider types that were not eligible to have Medicaid support for health information exchange. So I think we have some interest among this group in coordinating care. So, as I already said, this is something that we already had. So, and I don't know everybody's familiarity with some of these programs, so if I'm oversimplifying or telling you things you already know, my apologies. But, you know, the Recovery Act contained within it the HITECH Act, which incentivized doctors and hospitals to use electronic health records. Those electronic health records had to meet certain standards, and that program was administered both by Medicaid and Medicare. On the Medicaid side, there is funds to provide the incentives, but also funds to support the state's Medicaid agencies as they supported their providers in this program. And that support for providers, for Medicaid providers, included health information exchange support. So if the state Medicaid agency wanted to build a health information exchange that helped primary care clinicians connect to acute care hospitals, they could do that. However, they were sort of limited because that was the incentive-eligible providers that they could only really were limited in connecting. So they were called eligible professionals and eligible hospitals. So you could build health information exchanges, but it was only within that rather small universe of providers. But even within that small universe, we gave out $350 million as of maybe about a year ago. So the trend of that keeps increasing, and so we're encouraged, but it was never quite enough because Medicaid agencies were telling us, what we already knew, which is that Medicaid providers want to connect with other kinds of providers. They don't just want to have a health information exchange that coordinates care between acute care hospitals and primary care hospitals. They want to talk to long-term care providers, to behavioral health providers, to substance abuse treatment providers, to home health providers, to social workers, to any other Medicaid provider, because the continuum of care on the Medicaid side is broad, and you have patients with multiple chronic conditions, and you really need to pull in lots of providers. So, revisiting the statute for when this guidance came out, we spent probably a year working on this. The statute was written broadly enough that we could advocate internally with the Office of General Counsel and the Office of Management and Budget in the White House that a reasonable interpretation was that you could expand this. And it was agreed that you could, and so we released a state Medicaid director's letter on February 29th, 2016 that dramatically opened up the financial support for health information exchanges to include all Medicaid providers. Hattie Slavitt, Dr. Karen DeSalvo released a blog in response to this. It came out at the same time the HIMSS contest did. The state Medicaid director's letter tied some conditions to this new expanded funding, but it's all very reasonable conditions. So it has to help meaningful use, and what that means, it has to help some of the objectives in the Meaningful Use program, which is an easy bar to meet in terms of from a policy point of view. System-wise, it's not, but policy-wise, it's very easy to see how some of these systems could help encourage meaningful use, because some of the objectives in meaningful use are things like transitions of care. So sending structured data from one provider to another provider to help them coordinate care for a Medicaid patient, or things like medication reconciliation, or care plan, or exchanging care plans from one provider to the other provider. So there are all these things that are very sort of logical in the Meaningful Use program, and really sort of unsurprising. There are two sort of big buckets of work. This is sort of we don't necessarily need to go into this. This is the actual language in the statute that allowed it. So there are two big, I'm going to jump around a little bit here, buckets of work this can support in terms of health information exchange. It can support onboarding and architecture. And I'm going to go into that a bit later on in detail, but I just want to sort of frame that for you to think about those elements as we progress. So the money always has to come to the state Medicaid agency, so that's worth emphasizing to this audience. So you have to have good relationships with your state Medicaid agency. If you don't have good relationships with your state Medicaid agency, or you don't have any relationships with your state Medicaid agency, let us know. We are happy to convene. So if you work for an agency and you'd like to talk to your state Medicaid agency, or this association would like to partner with a particular state Medicaid agency, we're happy to facilitate those conversations and see what we can do to facilitate some expanded health information exchange. So that's important to emphasize. The funding goes until 2021. It is for implementation only. What that means is it's just for the design, develop, implement phase of the health information exchange. We take a pretty generous view of that because implementation could take a while. If year, 18 months would not be unreasonable if you're onboarding them into a health information exchange. But it still does end, and then the latest it can go is 2021. And as you pull in the state Medicaid agency, we can really go over the specifics of it, but that's some high-level things that are worth understanding. So the two buckets of work, we have health information exchange architecture and onboarding. Architecture, I'm going to go into detail on some of these pieces, but it's worth looking at them and sort of framing them up with it. My system sort of keeps flipping from the page I'm putting it on. The other piece of work is onboarding. Onboarding is somewhat intentionally broad as a term. What we mean by onboarding is both the administrative and technical steps of connecting to a health information exchange. So that's actually a heavy lift for a state Medicaid agency because you need lawyers, you need people to oftentimes physically go into a practice or to sit down with a clinician to onboard them. Onboarding might mean, or the administrative piece of onboarding could include the consent models, sort of establishing the consent models, looking at contracts, looking at business associate agreements under HIPAA, looking at the technical side of onboarding. It involves establishing that secure connection, looking at encryption standards, looking at the certificates. When I say certificates, I mean the electronic certificates you need for interoperability. So looking at those technical pieces to establish interoperability. And that's most likely what states are going to use the money for. And in our experience, that's what they're using it for first. They're expanding a lot of their architecture, but onboarding is more popular, we're seeing. Some of these use cases, these pieces of architecture, I think are particularly relevant to this audience because a lot of them can connect home care or some of the other provider types represented by your associations. So I want to go over some of these, and I apologize again if I'm sort of simplifying things that you already understand. I just want to make sure that I cover everything thoroughly. So a provider directory can be supported, and now it can support all Medicaid providers. And what a provider directory does is it sort of serves as a white pages for clinicians. So one clinician can go to a provider directory, look up another clinician, and submit a transition of care. They can submit structured data on a patient. They could submit the problem list, discharge instructions. They could submit free text. A lot of the systems have a sort of basically secure email functionality. It allows for that sort of coordination across many different provider types who otherwise wouldn't have a means of connecting. And one important thing to remember about the provider directories is that the state is really only worried about the incentive eligible provider. Not only worried about it, but like the basis of the funding is the incentive eligible provider, so that acute care hospital and the primary care clinicians. But there is no reason that we can't build provider directories that are web-based, so with a cloud-based, web-based functionality. So what could happen, the way it could work, and we're advising some states to consider this model when you're thinking about provider types who maybe don't have a high rate of EHR adoption, is to think of these cloud-based services. So let's think through how that would work for home health agencies who maybe don't have access to an electronic health record, or the electronic health record you have isn't that good or has limited connectivity. You could go in as a primary care clinician or acute care hospital to a web-based product where they could connect via their EHR, submit a transition of care that was then picked up by a home health agency over the web, where the home health agency could, the reverse, submit information from the web that made its way to primary care clinicians or an acute care hospital. So the ability for a state to build some of these cloud-based systems is really helpful for some of the provider types represented here today. So I want to really flag that for everybody here. And similarly, secure messaging is that layer underneath the provider directory, but not limited to being in a provider directory. That is very important for health information exchange. That's the actual connection. So the actual, think of it as an email address that can also contain structured data as well as messages that goes through a health information exchange. So that can be supported by this funding. Encounter alerting. So encounter alerting is a great use for health information exchange, particularly that deals with or home health into acute care hospital, however the flow might be. An encounter alerting system can let everybody who needs to know about these changes in admission, discharge, or transfer. They can be configured to include different provider types. So it can include social workers, it can include case managers or home health workers or other sorts of members of the care team. And it can start as just a bell that goes off, hey, this patient was admitted to the emergency department, the case manager should follow up. And that bell can be followed by structured data. Oh, and here is their medication history. Here's their problem list. Here are, 5 years of abstracted data on some particular condition. It's very important that everybody have in front of them. So it can really respond to the needs of the clinicians involved. So we're not overly prescriptive in what those feeds contain, as long as they do support the meaningful use objective. So Care Plan Exchange is another complement to the series of tools that helps the multiple chronic conditions. So Care Plan Exchange is that shared electronic document that follows a patient from care setting to care setting. So thinking, say, a non-compliant diabetic. So a non-compliant diabetic might have a care team that includes, endocrinologist, a cardiologist, a nephrologist, primary care. Maybe they've been admitted to a hospital. Maybe they have a case manager. So they have all of these people in their care team, and they're getting home dialysis. So they have those concerns and all these other concerns, and it's good to have one one fixed care plan that other people can look at, edit, including the patient, make changes, set goals. So maybe a goal around A1C or a goal around other lab values or sort of activities of daily living, what have you. So you can have this sort of collaborative document that can also be supported by the fund. And actually, I think I might have skipped over this. So the funding itself is 90-10. So the state Medicaid agency has to go with 10%, and we match it. We CMS matches it at 90%. So it's a great deal, right? That's a huge cost relief to the states looking to make these investments. So I forgot to actually give that ratio. My apologies. There are some standards around care plans. There's some standards around a lot of these. If we pull in the state Medicaid agencies to these conversations, we can dig deeper into what that looks like with those standards. We don't, obviously, since we are a standard-setting organization, it's nothing exotic. It's things that you would hope that would foster interoperability that we request in these systems. And where there is no standard, the states are allowed to do whatever they choose, though we do also have softer guidance on some standards used, because there's some standards that are maybe less mature or less widely adopted. And we have a lot of documentation on what those standards are and whether or not we would recommend them. And we ONC, the Office of National Coordinator, are also happy to help the state Medicaid agency think through the pros and cons of this, and something we do pretty regularly as we have conversations with states looking to establish these. If they have any questions, we will generally sit down and walk them through it. So a HITECH service, it's a lot like onboarding, but it's a little more fixed. So a HITECH service is sort of the governance entity that sits over Health Information Exchange. So they'll have that same sort of dual role of administrative and technical, sitting over a Health Information Exchange. So looking at both the encryption standards, the direct secure connections, as well as the governance certificates and whatnot. And where HISPs maybe do more than onboarding is when you get into the states that have maybe more of a network of networks feel. So you have a health system, a health information exchange. That's like a regional health information exchange, and like another health system, and then another health information exchange. So I think of Pennsylvania, like you maybe have a health information exchange in Philadelphia, a health information exchange at UPMC on the Pittsburgh side. You have Geisinger in the middle. You have some smaller entities and health systems peppered throughout. So you have different health information exchanges doing different things. But you, as Pennsylvania, want to do statewide services. You want to have a shared service layer that sends data from one side of the state to the other, and you want to sort of wrangle all these various entities, that's where HISP services can really help, because they can coordinate the various somewhat fragmented players that might be in some of these larger states. So HISP services can help negotiate some of those difficulties very nicely, because it's, again, 9-10 support for those services, and they have that governance function. Query exchange is really something that states have been most interested in. We at ONC were somewhat slow to support, and I guess this is CMS support for it financially, mostly because the standards are very, not immature, but they're less mature, I would say. So if you have a query exchange, you have to think about what that involves. So query exchange is you're essentially a clinician asking a question to a clinical data warehouse or to some sort of data repository, and there are several transactions involved there. So you're asking the question, and then you're getting an answer, or you're asking the question, and then it has to authenticate that you have an association with the patient, and state privacy rules vary. So what you need to provide is going to differ from state to state, and it might differ based on the kind of information you're requesting. You might need to do data segmentation, if it's behavioral health data or substance abuse data. So there's a lot sort of less established governance practices around query exchange, but we don't view that as a hindrance to supporting it. So we know how to do it. We've partnered with the Office of Civil Rights and SAMHSA on pushing out guidance on how to do these kinds of health information exchange. And query exchange in particular is popular among states because a lot of states have a Medicaid architecture that already had a clinical data warehouse. So they already had a clinical data warehouse that had administrative data, which we all know is great, but it is something. And then that administrative data has been complemented with more and more encounter data that is more and more clinical, maybe HITECH data, other sorts of data points that do make it attractive for some kind of query exchange on the health information exchange front. So public health systems. So earlier I said that onboarding was some of the most popular uses of these funds. I'm looking at the various state Medicaid agency applications for these funds, and the second most common that I'm seeing is public health systems. So a state can use this 90-10 funds to support public health systems, again, if they support meaningful use. So meaningful use requires a clinician to support reporting to immunization registries, syndromic surveillance registries, electronic lab reporting. And I want to stop for a moment to talk about specialty registries for a moment. That's something else the state can use to this 90-10 fund to build a registry around. And it's intentionally broad, what a specialty registry is. We rolled it out in Meaningful Use Stage 2, and it continues in Meaningful Use Stage 3, somewhat in response to clinicians who argued that a lot of these reporting requirements in Meaningful Use really made no sense to their scope of practice. Like they aren't the kind of clinicians who had any business submitting information to an immunization registry or syndromic surveillance, yet they had to if they wanted to either get their incentive payment or avoid a payment adjustment. So in response to that, what has been very popular is this wide latitude to support specialty registries. So if a state looks at their health landscape and identifies priorities, the state can build a specialty registry that speaks to their priorities. So what we're seeing already are some very interesting things. Michigan, looking at a lead registry. I'm actively working with Puerto Rico and some other states on a Zika registry. Washington, D.C. wants to do a homelessness registry. Colorado just had approved a registry around advanced directives and a registry around case management. So this sort of single point where you coordinate some of these conditions that permeate the state that you have identified as a priority for your state. It could also be things like HIV or hepatitis or other immunization or infectious diseases that don't really have a dedicated registry that maybe need more dedicated attention. So it's something that I think there's opportunities there for a lot of collaboration with home health and some of the other provider types on this call. I see the specialty registry in particular is a way of getting, some of the more sort of home-based patients there who we need more information on them to get the word out to the state public health associations as to what they have, how to help them, and how to reach out to them and build case management to support them. So I don't know if I need to go into the interoperability standards other than to tell you that they exist. We have an emphasis in Medicaid on cost effectiveness, modularity. If we build something, we want to use it for other things. So if we're going to build one of these health information exchange systems, we don't want it just to support meaningful use. To get approved, it has to support meaningful use, but it also is something we want the state to use for ACOs. We want the state to use it for medical homes. We want the state to use it for the hospital readmission pilot or some other delivery system reform activity. We want them to consider it. So we have a lot of emphasis of that on the Medicaid side that is important to us and that we do enforce throughout the Medicaid approval process. I don't know if we need to go into all of that. But we do have the standards, and the standards are aligned between CMS and the Office of National Coordinator and your electronic health records. So for providers who have been participating in the incentive program, the standards that are required in that electronic health record are standards that will be aligned with what Medicaid can support. So that works out well, right? That anything that is in your EHR will be in a proper format for these interoperable exchanges, and you still have all that in-between space that we need to regulate, but on a basic level, most EHRs will be able to support these kinds of activities. So there's a cost allocation requirement at the state level, so if your state is interested in doing some of these projects, we do have to ask them to cost allocate it. So what that means is if a state is wanting to build a statewide system, and your state is only 40% Medicaid, then we can only pay for 40% of whatever you're building. A lot of the new work, though, is very Medicaid heavy or Medicaid front-loaded, so the cost allocation doesn't come up as often, but it does still come up. So if your state is looking at that, that's something to consider. If it's not a Medicaid-only activity, it is a requirement under the Office of Management and Budget that cost allocation be completed. So CMS does oversee all of these funds. We work with the state to help them create their requests to us, set some benchmarks. So let me speak a bit about benchmarks. So again, I also said that we take a wide view of implementation. So for example, if a state decided they wanted to onboard all home health care providers to a health information exchange, a benchmark that they would maybe use would be 95% of home health providers will be connected to our health information exchange, and then we will consider ourselves implemented. That's fine. Like, we don't mind aggressive timelines like that or aggressive targets like that. And we additionally want strong definitions of what it means to be implemented. So it doesn't necessarily mean just establishing that connection for the home health provider. It could mean establishing that connection. Some entity goes, sits down with the home health provider, tests the connection, sends test data, sends production data to make sure that everybody is actually connected and that the systems work as we want them to work. So we can set that as part of the benchmarks tied to our funding with the state Medicaid agency. The state Medicaid agency is usually agreeable to that because they want the data to really flow. It's not one of these situations where you need to really skimp because it's a very generous match, so the state can usually find the funds to support that more aggressive definition of onboarding. And there's also things that the state already could have used the 90/10 support for that continue to be true, that we've been really communicating to the states lately that they should continue to think about planning for expanding health information exchange, but that planning now includes a broader universe of providers. So that planning now includes home health, behavioral health, substance abuse treatments, long-term care, correctional health, like all sorts of provider types who maybe weren't covered before. And if anybody has any questions about any of these points, I can dig into them personally. And again, this is all really on the path towards delivery system reform because, as we said, we care about scalability, we care about reusability, and these all really support the new delivery system reform programs in helping you coordinate care. Because if you don't have these systems, you can't build an ACO that coordinates a patient as they move from a hospital to a provider to a specialist to home care and whatnot. So as you build these new models that emphasize quality over quantity, you need these systems. It's sort of self-evident, but sadly they weren't paid for. Now they can be paid for. So this is we think very encouraging. We're very excited about it, and I am happy to answer questions about it. That's my email at the bottom there. There's another email top there, the Broadening address. You can send questions there as well, or if you maybe send them to me and CC me. I'm doing some FAQs that I'm gathering on this state Medicaid director's letter. So it helps me, actually, if you CC that Broadening address, because I'm using Broadening to help me collate the questions and gather them so that I make sure I answer all of them in the forthcoming FAQ document. And that is something that we'll release as well. And that is my email address. In addition to answering your questions now, I want to throw it out there that if you want to ask me to see if I can coordinate something with you and your state Medicaid agency, I can do that. You should know that you're going to be competing. There are going to be other provider types out there interested in this new opportunity. So it's best to frame your argument well if you're looking to be supported by some of this health information exchange activity. So you're looking at long-term care, behavioral health, some high-cost services. It's always good to bring data and cost data to the table and outcome data to the table. So if you want to partner with the state Medicaid agency to do some of this work, it's best to explain how the work you do ties into helping the patients with multiple chronic conditions who are very, very expensive, or the patients who really find that they get improved quality outcomes through these sorts of connections, through care plan exchange, through direct connections to acute care hospitals, giving their discharge instructions right to home care directly without a paper trail or sort of this sort of game of telephone of the caretakers getting in the middle, so that we have this sort of reliable pathway back and forth, and a pathway to ask questions to clinicians. So it's best to frame yourself as part of that continuum in approaching state Medicaid agencies, because they're receiving a lot of requests to use these funds, and that's always the best way to advocate for yourself, to show how the work you do helps these Medicaid patients. So that said, Teresa, I'm good for questions. I can answer them, and happy to go into detail on any of these slides or answer any questions.
Fantastic. Thank you so much. And, that was a great deal of information in a short period of time. We've already gotten some questions asking about access to your slides, and we'll make sure to post and post the slides on our website and also on VNAA's website, and also just email the link out to everybody so that you can access it. So I've got one question here. This is a question from John Durr. Tom, is there any control of the onboarding costs? I have heard of a SNF being charged $2,000 a month. The costs are all over the place.
The costs are all over the place. And is that John Durr from New York? In any case. So, and it's sort of defensible. So onboarding a SNF that has no electronic health record is going to be more expensive than a SNF that's tied in closely to a health system that has Epic or Cerner, and it's just a question of connecting it via a node or via direct or something. So it's somewhat defensible, but it's not something that we just write a blank check for. So we do push back if the state makes a request for 400 interfaces. You can build the interface using this funding. but we're not going to build 400. Like, that's not efficient. That's not consistent with our principles of scalability and interoperability. There also, like, we've done this a lot. We know that there are ways to do it better. We know that you can use a node approach, or you can use direct if your EHR has direct to avoid building an interface at all. In some instances, sort of depending on the instance of the EHR. So there are ways around it, and we're getting clever. Like, we're getting a little creative with some of our funding approaches. So there is a requirement in Medicaid that unless something is copyrighted, the state owns it. So some states are in a position where they're sort of in that position where they have to build some expensive interfaces, and they don't want to any more than we want to pay for it. But what we are realizing we can do is, once the state owns it, we can post that online. We can put some documentation up describing the instance. We can post it on GitHub or some other similar website so that we are paying for it, we're building it, but we're only going to do it once. And then we're going to post it online and share it for everybody. So we haven't done that yet. We have to get some of the process around that together, but we have a few states that find themselves in a situation, and they're both obviously sort of rural states that will find themselves in a situation that don't have a sort of statewide health system presence that are going to need a bunch of interfaces. And we're like, okay, we'll build these interfaces, but we're going to try to do it in a way that we don't need to do it over and over again. So you're absolutely right. Onboarding costs are all over the place. We have a few tricks up our sleeve, and we're always all ears to hear more ideas, as well as always just, utilizing the web. Like, if it's a SNF that doesn't have an EHR, doesn't have a great EHR, we can also do a web-based provider directory or a web-based care plan exchange module that supports some of these systems that, maybe the SNF does have an EHR, but it's not interoperable, but they can still export a care plan to a web-based care plan exchange module or provider directory. So we try to work within that, and then we find that the costs can come down, but we do need to push back sometimes, because a lot of times there might be a consultant telling the state how much everything is going to cost. Understanding the text helps as we help the states negotiate some of these.
Okay, great. Thank you so much. So we've got another question. This one comes from Joy Cameron of VNAA. The question is, if you are an agency that serves both Medicare and Medicaid beneficiaries, or duals, do you need to carefully track the differences, or how does it work?
So what we care about is if you are a Medicaid provider, yes or no. So the state Medicaid agency can use these funds to support Medicaid providers. So there's no patient volume requirement around this, because it's all prospective. Like, it's all a system that we want to either build or onboard to that will theoretically help meaningful use. So the other requirement is to be a Medicaid provider. So you may not see a lot of Medicaid patients, that's not to say you won't in the future. Maybe even you see more once these systems are established. So we're not restricted or putting any sort of patient volume requirements around that. So it's mostly just that you're a Medicaid provider. And what that means is that you have a provider agreement with the Medicaid agency.
Okay, that's helpful. I've got a question. So I'm wondering so far what kind of feedback or response you've gotten from the state Medicaid agencies about this initiative.
So they're very receptive. They love it. It's maybe the state Medicaid agencies don't love it because they have to do a lot of work on it. They have to write all these requests and organize the work. But the community at large, like the the broader health IT community, is very excited because it does a lot for interoperability, and it does a lot for establishing these systems. They emphasize aligning standards, which we've always known, and we continue to prioritize because we don't want building systems that are not able to be reused for other things, which is something we share that concern. But overall, it's been very, very positive. I get to give a lot of presentations like this one to various associations and state Medicaid agencies and other stakeholders are wondering how this could help them, and it's very dynamic. It can help a lot of different stakeholders in a lot of different ways, and it's just sort of representative of the continuum of care. Like, you have all these different stakeholders involved, so it has a lot of angles that you maybe wouldn't even think of, like correctional health can be connected. As long as those providers are enrolled in Medicaid, they can submit data from, in prison, and you can track patients who, maybe had HIV or hepatitis, and connect them to specialty care once they get released. They could, do all these things you maybe wouldn't have thought of. So it's kind of a lot of use cases that were needed. Social workers who are Medicaid providers can now go into a care plan. So kids in foster care who, it's hard to keep track of their medication history and allergies. Some states are now building more robust systems that can track those children as they move throughout the foster care system and make sure that they're not sort of restarting a medication every time a medication they know doesn't work appropriately as they move from family to family or what have you. So there's a lot of utility in it that we are just hadn't even considered ourselves that just sort of keep emerging.
Helpful, thank you. One more question. So I'm not sure if other communities affected by your new program, what their level of EHR adoption is like, but among Medicare home health agencies, there are still many agencies that don't really have electronic health, like an electronic health record system really in place yet. And just sort of thinking about the various uses or applications of the funding that you've outlined, I mean, if you were going to try to work with your state Medicaid agency to try to get funding, knowing that you've got a lot of agencies that, it's pretty nascent in terms of adoption of EHRs. I mean, which of the applications do you think, the applications of the funding, do you think you would try to go for?
So I keep it, and this isn't limited to this group. We have the same problem with behavioral health and substance abuse. Is that EHR adoption issue, and I keep saying provider directories that are web-based or care plan exchange that is web-based, because if you think through what that looks like, so, and these products exist, I'm not inventing them. So you have an EHR that maybe connects to these systems on the back end. So if you're an EHR user, it doesn't even look like you're on any system. It looks like you're just clicking submit to something in your EHR. It's integrated very well. And then it goes to a cloud-based website that then can be pulled off through either a message or a care plan or a medication history or a problem list. It goes to a cloud-based website that some other clinician can go into and pull that data down from, or the reverse. They can send it up. I was going to say up to the cloud. That sounded a little too literal, but you send it up to the cloud, and then get pulled down from the EHR of the acute care hospital or the primary care. So it integrates well, and it also sort of integrates nicely when you have maybe like a middle-of-the-road EHR. So maybe they have at the SNF or the long-term care, the home health agency, maybe they had an EHR, but it can't really do the sort of real-time connections that we're describing here. But it has maybe a basic export capability or an import capability. So you can still sort of connect to this online provider directory or care plan exchange. So it can still work, but it's maybe not as graceful as were it just to be all seamless within one EHR that didn't require any extra steps to coordinate the care. So some of those web-based options are the ones I try to point states toward.
Okay, that's great. I'm going to remind everybody that you can submit your questions via the chat box. Tom, I think that you've provided just so much interesting information here. I'm sure that all of us are going to need to, really pour through your slides just a little bit more and read the letter to the state Medicaid directors very closely. And because it's state by state, I anticipate that, at least for the organizations at the national level, we're going to want to coordinate with the state home care associations so that we can, sort of make that assessment, what is it that makes the most sense in any given state in terms of, reaching out to, the state Medicaid director and figuring out, what kind of program or funding could make sense for home health agencies in a given state. Do you have any advice for that kind of outreach, how to begin that conversation? And do you think that, the way you approach the conversation with a state Medicaid director might vary depending on the state that you're in?
It is going to vary because it's going to depend on how much money the state has. Like they still have to go to the 10%, which is not insignificant in some instances. And, the state has various priorities. So I'd always sort of think of my audience when approaching a Medicaid agency. It obviously helps to have these relationships. I assume many of you have at least some relationships with the state Medicaid agencies to talk these through. Some of the state Medicaid agencies may not be aware of the extent to which we can help home health and some of the other VNAA groups, in which case you can certainly invite me to speak to them. I'm speaking to most every state Medicaid agency anyway, so if you need me to flag something for them, or if there's some sort of initiative you're working on that you think would be well supported by some of this work, feel free to point that out to me, and I can flag it for them as well. We do a lot of that kind of convening, both at the Office of National Coordinator and at CMS, specifically the CMS HITECH team. So we sit down with the stakeholders in health information exchange in various states often. So we're happy to do that.
That's fantastic, and I think if they're not on this webinar now, I'm going to make sure to share this with all of our colleagues with the state home care associations, because I want to make sure we take you up on your offer before the end of the Obama administration. So anyway,
this money doesn't go anywhere. This money is Recovery Act money. It's already allocated.
Good. That's good. That's good to hear. Excellent.
Yeah.
So I guess the only other question that I had is whether or not there are other provider communities that have already, we're, sad to say we're really just learning about this now. Are you finding that there are other provider communities that have already, gotten extremely well organized and are already lobbying their state Medicaid directors to get funding through this process?
I'm not sure if I would say it's played out quite that way. The pharmacies always do a good job, so they read it and understood it immediately. So they're plugged in, but the state's interest is more important, and the states have been most interested in supporting public health and behavioral health. So there's a bit of a tension there, but so pharmacy groups are interested because it can support e-prescribe, it can support medication reconciliation, it can support a lot of things that we care about, and helps pharmacists and pharmacies with some of their health information exchange infrastructure, which the states do value, and many states are requesting support to that effect. But the states also want to support their public health activities and their behavioral health in particular, we're finding. So they're probably the first ones to the table so far that we're seeing, but we're now at the point where we're seeing everybody.
Okay, that's helpful. I think that it's, the reason why I ask is because I want to make sure that we all understand that this process can be somewhat competitive Given limited funds at the state level and given the multiple different types of organizations that could be eligible but would only be extended funding if the state Medicaid agency chooses to create some kind of a program that would get the matching funds for that specific type of provider.
Exactly.
All right. Well, I'm gonna suggest that to this community, to the home health community that we're communicating with today, that we need to get organized and make sure that we think hard but fast about the kinds of programs we might want to pursue.
Did your group go to the HCBS conference? I assume there's some fair bit of overlap there, right?
There is some overlap. I personally did not participate, but I'm sure that others did.
Okay, so there's an HCBS conference at the end of the summer that I'll be at as well. If anybody wants to sit down and hang out and kick around some ideas, I'll be presenting on this.
That would be great. We would welcome that opportunity, Tom. I did get one question. This is from Brett Sundblad. How do you acquire a voucher to enroll with an existing HIE? I'm in Florida, and they give you an option to use one. Does that make a difference in ongoing costs?
So it sounds like a process unique to Florida. You have to talk to the Florida Health Information Exchange people, but I could connect you with them. So I know they just recently requested an extension of their onboarding universe to sort of include a lot more provider types. So that, I think, is probably what you're referring to. So if you want, I can connect you with the right people if you just reach out to me.
Okay. Great. Very, very helpful, Tom. I think we're not seeing any other questions. So with that, I'll just remind everybody we did record this webinar. We're going to plan on posting the replay of the webinar on our organization's website. We're going to post the slides on the website as well. And I just want to thank you, Tom, for just being so open and willing to share information about this new ONC initiative. And we'll make sure to follow up because I think that your extension and your offer to help is just so very much appreciated because we obviously need to get organized and quickly mobilize if we want to be able to optimize the opportunity. So thank you so much, and I want to wish everybody a really great afternoon. Thank you.
All right. Likewise. Please reach out if you are so inclined.